Good morning, everyone. I must confess, very pleasantly surprised to see all of you here in this weather. I was expecting to see perhaps Diane and just having a dialogue with her and having coffee, but I'm so happy that this weather has not stopped you from making it in. So thank you for making the effort. I'm truly grateful. I know there are people at the other sites as well. And I'm sure we'll have a dialogue with them too. So let me just start off by asking, how many of you in the room are from the nursing profession? Quite a lot. That's great. And physicians? Okay, thank you for being here. Social work? Great. Allied health professionals like OT, PT. Oh, wow, that's fantastic. Anyone from the spiritual or pastoral care services? Okay, that's fine. I'm sure people will trickle in. So what I'm hoping to do this morning is have a conversation with you. I like to, even though this is a fairly big auditorium, and on the extended campuses, there's more people. I'm hoping to keep it fairly casual. If there's a burning question, don't hesitate to ask, and I will do my very best to continue to have this conversation with you and finish on time. But I want it to be an interactive dialogue as much as possible. Okay. What I'm hoping to do is for us to leave today with a slightly clearer understanding of an approach to this very challenging and complex issue that we all struggle with every day. But the only way we're going to make life better for ourselves in a few years is if we work hard at it now and treat our patients and our families with the sensitivity and the dignity that they deserve. And hopefully we'll get that benefit when we get there in a few years, which we will. Most of us in this room deal with some aspects of dementia. How many of you in the room do not deal with dementia at all? Okay, you wouldn't probably be here this early in the morning. Any thoughts or comments, or how does it feel when you hear this? Sorry? It's scary. Any other? Yes?
When I see the way that some of these patients behave on the wards,
yes,
and the medications required and the staff required, I wonder how they deal with that in the homes, when they have a couple of support workers overnight or whatever.
Yeah. That's a really good point. And a lot of my emphasis today is not going to be in the acute care setting. It'll be mostly in the long-term care setting, because a lot of these patients or residents actually go back there from here after they recover from their acute pneumonia or broken hip or whatnot. And I'd like us to be a bit more sensitive about that environment, which we often, it's not our scope, but it's not where we work. It's not our environment. Good point. Thank you. I'll take a couple of more comments. Yes, ma'am. Right. So so that's the other aspect, this is resident-to-resident violence is what they have emphasized. I will be talking a lot about the resident-to-staff, and lately it's staff-to-resident violence as well, which I'm not going to touch on today because it's more of there's more sort of moving parts to it than I can address today. Yeah. Yes, ma'am.
Seem to lead to medication and sedation type of things as being the only way we can deal with this, and just worry about all the implications of that.
Yeah, I'm sorry. I know the other sites are listening and you don't have a microphone, so I will try and repeat the comments. Thank you, Diane, for reminding me. Absolutely, your comment is perfect, which is that you feel helpless and hopeless even sometimes because we try and fix this very complex, multifactorial problem with a single solution. which is chemical or physical restraints. And a lot of my talk today will be focused on that, to say that may be a necessary, so this is one key message, it might be necessary to use at certain points, but it's not the complete answer. And not that I have the complete answer, but we need to think about that. Okay, so allow me to go on. We for sure will have time to talk. The objectives today are to assess a person with aggression, manage a person with aggression, and think about not just the pharmacological, but also non-pharmacological approaches, and use your innovative, plastic, flexible ideas to come up with solutions which are patient or resident-centered. Okay. So this is a colleague of mine. He's a physician. Some of you may recognize him. It's Dr. Alan Buchanan from Vancouver. And he's trying to get some sleep on a night on call, right? And who do you think's on the other end of the line at 3 in the morning? Usually a nurse from, and what do you think he or she is telling him? Mr. Jones in room 285 is aggressive. Please give me something, medication-wise, right? How do you think he feels? He doesn't even know the patient. There's lots of doctors in the room. Have you had calls like this? Anyone? How do you feel? Why me, right? It's why me. The same feeling you get when you go down to Emerge and you see someone who's 85, who's presenting with behavioral, like agitation or aggression or psychotic symptoms at 2 in the morning. So it's not really an easy, if this call was about, if this is a family physician and he gets a call about a child with an earache, he could do it almost literally in his sleep, right? But it's not so easy with these complex presentations, right? Or even chest pain. You can deal with those things because the algorithm is more linear, right? It's the clinical pathway. You do A, B, C, D, E, otherwise, and these are the medications. And thank you very much. See you tomorrow. But these are not simple or linear pathways. But here's a way to think about it. So this is how I think about it, and it helps me, and I suggest that it might be useful. So the first thing that we're all after is safety, not just the safety of the patient, other residents, and staff as well. So we need to absolutely think about it, and the types of questions you want to ask to get that information are crucial. So you need to have a team on both sides who are trained and have a good working relationship with you, so that when they pick up the phone and call you, they're giving you the pertinent behavioral vital signs, right? And we'll talk about that in a few minutes. On the medium term, which can, often you can still go back to sleep if you can deal with it on the phone and go and see the patient in a few hours. You can order some blood work, rule out a delirium, and then decide what to use for medication, if you need to use medication at all. And then there's the whole long-term. So it's the short and medium and long-term planning for this. And it's not just it's not as simple as having a sore throat and a week-long course of antibiotics will take care of it. So it does require short, medium, and long-term planning. Now, when they present, it often presents as a delirium, because that's what happens when a person who's generally quite well in the community and is managing fine, thank you very much, even if they're demented or dementing, they still have enough brain reserve so they can manage well. But these people who have a fixed genetic background, their personalities are fixed. I call them the spots on a leopard. You cannot change those things, right? You're born with your genes and your personality, and the way you were raised and your psychosocial background are in that black box. You cannot change that. But then you layer the sandwich of dementia, which happens to a lot of people, as you know. Often they're depressed, and then they get pneumonia, or they end up with a broken hip, or they get put on an anticholinergic drug. And guess what happens? They end up with a delirium. And they end up in your emergency room, or the phone call is triggered, right? And that's what you have to deal with. So comorbidity is the rule, it's not an exception. Now, let's go back to basics, ABC. So I like to think very simply about things. It helps me remember things and deal with it when things get really rocky. So dementia is made up of these three domains: activities of daily living, behavioral changes, and cognitive changes. If you follow a person with dementia over time, the cognitive domain declines at a fairly predictable rate. You start with a mini-mental or a MoCA of 30. Every year they lose so many points, at least in the middle part of the illness. Similarly, the activities of daily living, or IADLs, are predictable. They lose the more complex functions first, and then the basic ones, and finally they lose all bowel, bladder functions, etc. But the behavioral domain is not so predictable. This is part of the problem, is we don't really know how an individual's behavioral trajectory will be, even though we know that 90% of these patients who have dementia will have some behavioral disturbance during the course of their life. So that's part of the challenge. Now, so let's look at the problem. The problem and the impact. I think Global tried to summarize a little bit of it on the video, but this is a serious issue, especially in long-term care. It affects both residents and staff, and up to 2 out of 3 staff are assaulted in nursing homes at least 1 to 9 times per month. Okay, 1 to 9 times per month. So there's the resident-to-resident violence as well, which we've talked about briefly. And a lot of this is because we're mixing residents who have dementia with those who do not have dementia. And there is a lot of deficits in the quality of care, not because the staff don't care, but it's because they're undertrained and understaffed. These environments are not ideal environments. And up to 40% of these incidents require medical treatment, and they are all kinds of them. You saw a fall there. There's a lot of fractures, lacerations can result. There's psychological wounds as well. People get very anxious when they're hurt, or they're living around someone who's aggressive. They're anxious, their quality of life is very poor. And so our job is to promote a safety of culture. And as we go through this morning, I'm hoping that we can pause a little bit, take time from our busy practices, which we'll go back to in an hour, but just reflect on what we can do to make it better for these patients. What actually happens? Well, there's a lot of things that happen, but one of the biggest issues, at least when nurses are being assaulted, is when they're rushed, when they're hurried. So if you don't take your time and talk to patients and approach them in a slow, calm way, that's when you get hit the most. It often happens during patients being transferred or being turned or being bathed or getting personal care. Those are the bulk of the assaults that take place. And there's a whole variety of symptoms, and you can see both physical and verbal aggression, and sexual sort of advances are less common, but it does happen as well. Okay. So let's look at the barriers. What are some of the obstacles in terms of why we can't, why it's so difficult? So there are basically four factors. One is the resident-related factors, where their health status has changed. When people are healthy, like we are in this room, we generally don't tend to get aggressive, right? But it's some change in our health that tends to lower our threshold for frustration tolerance. Think of a threshold we all have a threshold. I bet you I can make anyone here upset or angry if I wanted to, right? I hope, because that's normal human behavior. But the threshold is lowered when you have dementia, or you have medical problems, or you have pain, and that's a good thing to keep in mind. There's the environment. The environment is there's lots of deficits. These residents are all boxed in together. there's lack of space, noise, you can think of it. There's organizational barriers such as staff and funding constraints and lack of training. And that's an important one because that's something we can do something about, and I'll be emphasizing that a number of times. And these intersect in when you see a major incident, they all come together in a perfect storm. And if you do critical analyses on these incidents, it's always the same thing. And the one thing I didn't put up here is communication, which is universal. People don't talk to each other. Okay. So let's talk about each of them very briefly. So we've talked about the multiple medical and psychiatric social comorbidities, but there's polypharmacy. These people are on a lot of medications that often help in lowering that threshold. There's functional impairment. They're not capable of making these decisions. Many of them do not understand what's going on around them, so that makes it really tough for them to communicate effectively. Use of psychotropic medications. At least half of these patients are taking some kind of psychotropic drugs. And they're on anxiolytics and antipsychotics. The use of antipsychotics, by the way, has gone up 20% in the last few years. And this is a very, very high public concern. So on one hand, we have the problem, if you want to call it a problem or a challenge, of increased violence and aggression. We have more and more people going into long-term care. On the other hand, the pressure is on us to not prescribe as much. So how do you balance that? And that's partly what I'm going to talk about. Okay. So what about the physical and chemical restraints? What do they do? Well, they actually make these patients worse. The rate of injuries when you use physical restraints such as jerry chairs or posy vests, they actually end up getting these patients more agitated, more delirious, and it's been shown that people who are treated with antipsychotics on an ongoing basis have an odds ratio of 1.74 for getting into difficulty. And for physical restraints, it's even higher. It's 1.79. Now, who gets assaulted? Like, we're not talking about resident-to-resident violence, but resident-to-staff. Most of these people are not physicians. Most of them are not RNs. They're nurses' aides. They're the ones who are directly interacting during personal care. And it's been shown that if you train these people to manage these patients with simple behavioral management skills, which only half of them, in some studies, 2/3 of them receive, not all of them, it reduces the rate of violence by 50%. Doesn't make it go away, but it reduces the risk a lot. And there's less physical and chemical restraints used, and non-pharmacological approaches to address these behaviors become the number one approach. It's really the approach. And these people mean to do well, but they don't know how to. Okay, so it makes sense. So I would say that that's one of our key take-homes today. Go back and influence your organizations, the people you work with, to train your staff in the GPA is one of the things. Gentle, persuasive approach is the way to go. Every nurse in this hospital should have that training, and so should a nurse's aide and an orderly. I would strongly advocate for that. Okay. All right, what about patient risk factors? Well, the number one factor is cognitive impairment, which almost all of them have. And if you correlate the cognitive impairment to aggression, both verbal and physical, and this is really interesting. So just follow me for a minute. If you look at mild to moderate cognitive impairment, you see that the rate of verbal and physical aggression is almost the same, right? It's 2 to 2 to 3. So most of them actually give you some verbal advance warning. They actually tend to give you some prodromal, symptoms that I'm going to beat you or I'm going to get agitated. Look at the more severe ones. The verbal aggression is very low. they go straight to the physical aggression, right? It's 8 times greater in more severely demented patients. They don't have the emotional breaks to even give you a warning. So when you're dealing with the more severely demented patients, you're more likely to get physically hurt. That's what it means. Males, people who are 65 to 84, and often if there's an emotional or psychiatric component to it, that's what lowers their seizure threshold. Not seizure, sorry, frustration tolerance. I deal with ECT, so that comes more easily to me. I'm sorry. Okay, what about staff risk? Well, these are fairly intuitively obvious things where you have a high resident to staff ratio, staff workload issues, staff anger scores. If you have a happier group of people who are not angry, the rate of violence in those facilities is lower. Okay? And if your staff feel trained and more competent, the rate is much lower. But if the opposite is true, if they feel untrained or unequipped to deal with it, the rate is much higher. And age has something to do with it here as well. The younger staff who haven't had the experience get into trouble more often. Okay. What are the protective factors? Well, you just flip that around. So you have a higher staff to resident ratio. Places that have those actually do better. If they choose to work on a high-risk unit, there are people who actually choose to work in these places, and they come in with more experience and confidence, right? And they do better. If the workplace is designed better for dementia patients, they seem to have a better outcome. Specialized education helps a lot. Not just educating them and then saying go and work in the same places, don't help them to implement it. You need to follow through. Don't just send them to a course and say, now you're trained, let's see some results. You actually need to support them and follow through on that. Otherwise, there's no point in sending them to training. You might as well, spend your money doing something else. So greater level of overall satisfaction with work and colleagues is very important. The staff need to be happy and not angry and frustrated, because when you have too frustrated group of people, you get fired more easily. Okay. Now, what about the environment and family? This is, again, underutilized. I think we pay very little attention to the environment and how we can use the family to support us. There are many countries in this world that don't have nearly as much staffing or budgets that we do in Canada. We spend $50 billion in healthcare, and I don't think we get the return we should for the amount of money we spend. Many countries only have family members to deal with this, okay? And they still have, better outcomes in many situations. They manage their loved ones much better than we do. They don't have facilities, they have fewer staff. So I think but our families are stressed as well. There was I just heard it on the news this morning. Did anyone else hear it? This old man in Kemptville, I think, ran out of money, and so he had to go and sell. He was taking care of his dementing wife. He sold his wedding ring to pay for their food, and the police found out, and the Alzheimer's Society is involved, so they've got the ring back for him. But families are extremely stressed in taking care of these people at home. And so, anyway, let me come back to my talk. But I think that's an underutilized area. We need to think about that a bit more. So reduced levels of environmental stimulation, crowding, looking at solutions to meet the needs better. And also, what about the interactions? When they come to visit, how can we use that as a positive thing? So we need to encourage families to come and visit more often, both in an acute care setting, but also in long-term care. It actually calms the patient down a lot. They don't feel so isolated. It maintains communication with us, and it reduces the risk of dehumanizing. Sometimes staff don't even know who the families are, and that's not okay. But it also helps update the family. The more you communicate with the family, the less your chances are of them getting upset with you. I've had conversations with a lot of the doctors here. I see Dr. Stewart here, and Dr. Brigham. And, the number one stress that we often have are the one or two or three families that are very challenging. So the better we communicate with them, the better off I think that they feel that we actually work with them. Anyway, so now those are the factors, the barriers, and what we have some work to do there. Now what about the clinical approach? How do we approach this situation? So the first thing we need to do is define what we mean. Okay, we have to have a clear definition of what aggression means, understand the contributing factors, improve our communication around it, because we have to talk the same language. Otherwise, when you make that call or when we come to do rounds, if we don't know what the patient's been like over the past 24 hours, we can't prescribe, we can't even begin to understand what to do. And teaching of de-escalation techniques. So I've just listed a few here. We have very experts, high-level expertise in this room on behavioral support. Especially the nurses here are amazing. And they, Diane has done an excellent job of leading our behavioral support team here, the behavioral support program in the community, and I see several people from GPCSO here in Royal Ottawa Hospital who run a behavioral support program. So if any one of you has questions about these, please approach us separately and we'll try and address those. But I'm not going to spend a lot of time talking about this right now, but they're really the crux, the centerpiece of managing these patients, is how you approach them, looking at their schedules, looking at reducing the demands on them, communicating with them using non-verbal communication, providing meticulous personal care for them, and looking at the activities and environment. Okay. So, for example, looking at them in the eye and talking to them, making positive statements, using simple one-step commands, allowing the residents to respond. If you want them to do something, don't just go and do it for them, but actually give them an opportunity to do it themselves independently. Discourage negative comments. For sure, you don't want to be condescending, critical, giving them multiple commands, announcing a lot of activities that are going on, arguing with them. It does not help. And distraction. If they're, being agitated, it's much better to distract them. Remember, they have a poor memory, so use that to their therapeutic advantage. And the last thing that's here is giving your staff some time off the ward or off the unit, more coffee breaks, more time out, so that they can go and come back feeling refreshed and replenished. Because it's physicians particularly are bad, I think, in going in, because we're only there for a few minutes or a couple of hours at the most. These nurses are there, and nurses' aides are there for 8, 10, 12-hour shifts. And if they don't get a break, it just lowers their frustration tolerance. So we need to schedule more frequent breaks for them. So behavioral and psychological symptoms now occur in all forms of dementia. They occur in Alzheimer's disease, they occur in vascular dementia, Lewy body dementias, but the way they present are slightly different. And it's nice to be able to see some of those differences, and sometimes it helps you with the pharmacological management. I'm shifting now a little bit to the pharmacology. We know that this leads to people leaving their homes and coming into hospital. It's the number one cause of people being institutionalized, is aggression and poorer quality of life. There are criteria in the DSM for psychosis of Alzheimer's disease, and these are listed here. You can look at these as well as I can. But the point I'm trying to make is that when you see psychotic symptoms in an older person, forget that. If you see someone who's 18 or 20 years old in your emergency room or in your office, and they're psychotic, what are the two things you think of right away? Schizophrenia and drugs, right? very easy. Those are the two that accounts for probably 95% of patients. But if you see someone who's 85 who is psychotic, you can't limit that. You have to go with the whole kit and caboodle. You need to cast a wide net, because you start with delirium, but you could have any of the other psychiatric and medical conditions that you need to think of. Which is why that phone call at 3 in the morning is not pleasant, because it's complex. And I didn't even add the long list of psychosocial problems here, right? Which makes it even more interesting and challenging. But that's what keeps us, stimulated, right? So we've talked about this, comorbidity is the rule. Now, what about medications? I'm now shifting gears a little bit. We've talked a lot about the barriers, we've talked about the environment, the approach. What about medications? The last half or third of my talk will be on this. So this is really important, that medications are important to use, they're necessary, but they're never sufficient by themselves. Okay. Now, psychotic symptoms are not uncommon. If you go into the community and pick out 100 people who are over 65, 1 out of 20 of them, or 5% of the 100, will have some psychotic symptoms. They don't all need to be treated with medications. As long as they're safe and they're functioning well, medications are not necessary. If you go into long-term care, up to 50% of them have some psychotic symptoms. Again, do they need treatment with medications? No. If they are safe and managing well, they're not interfering with anyone else, don't worry about the drugs. And similarly, we see a lot of deliriums here in the hospital. They may need medications for a few days, and then someone needs to monitor them so that they don't necessarily go home and stay on them forever. And I think that is one of the key things we need to learn about antipsychotics. The problems with antipsychotics in long-term care, this is not new. It goes back to the 50s and 60s. When these drugs came out, when chlorpromazine and Haldol came out in the 50s and 60s, everyone started to use them. And no one was worried about what they were using it for. There was inadequate assessments, prescriptions were written, willy-nilly. There was no investigations done, but we didn't know about them. It's not like we were trying to harm our patients. We just had lots of blind spots then. And we wanted to have a quick fix, so we wanted to keep the nurses safe and the residents, quiet. So it just, grew like that. The side effects were not recognized. We didn't know what the side effects were. We just found out about the high rate of tardive dyskinesia with these drugs about 10, 15 years ago in older patients. And psychiatric services were not available then to help with this. So with the newer drugs, now we have newer drugs like risperidone, olanzapine, Seroquel, Abilify. They're thought to be safer, but we have different problems with them, right? And we're starting to develop a better sense of what they are now. So the writing is on the wall. Whether you choose to read it or not is up to you. But these drugs, if you're going to use them, they have to be used properly, or it's likely to get you into trouble. Okay? So in recent years, I'll just read this out. Medicaid, this is from the US, has spent more money on antipsychotic drugs for Americans than on any other class of pharmaceuticals, including antibiotics, AIDS, or medicine to treat high blood pressure. And this is in the Wall Street Journal in 2007. And the reason is nursing homes across the US are giving these drugs to elderly to quiet symptoms of Alzheimer's disease and forms of dementia. This is from the American Journal of Medicine for long-term care physicians. The top 4 or 5 drugs which cause problems are psychiatric or psychotropic drugs, or atypicals being right on top of that list. Back in 2004, the media caught this story about antipsychotic drugs causing high rates of mortality and stroke-like events. And then this is a page from yourlawyer.com. It's a really good website. You should check it from time to time. They know about these things way before we do. And then and they go and have big lawsuits in the States. It also talks about other drugs, not just antipsychotics. And I think that here, these are the drugs like even Aricept, Zantac, Detrol, other anticholinergic drugs are linked to mental impairment, or linked, it's a typo there, to impairment in the elderly. So they know that these drugs are bad for these. And there are lots of warnings out there. There's big black box warnings, there's randomized controlled trials, Cochrane review, all leading to the black box warnings about these drugs. Okay? And basically what it says is these drugs, when compared to placebo, there's a 1.6 to 1.7 times risk of death when you use these drugs in patients with dementia. Okay? And your families know this. They Google it and they see the big black box warning. So if you're using these drugs, please, for heaven's sake, tell them. When you Google this, you'll find it. But right now, that's the risk we have to take. But I promise you, and I pledge that I will follow your loved one very closely, and will try and keep the doses as low as possible for as short a time as possible. And when they leave the hospital, I'll make sure someone will take care of your loved one, right? Then they give you consent. Without that consent, someone is going to come out from somewhere and sue. And that happens in the States more than it happens here. So our goal is first to do no harm. Second, when we took that Hippocratic oath, we said we'll do no harm. We'll do our best to improve the quality of life of our patients. And we must assess the risk and the benefit of every intervention and look at all treatment options, not just a drug, look at all treatment options. And that's where our behavioral support team is extremely helpful in these patients, because the two nurses we have, and we're hoping that we'll get more, are doing a lot of this work with your teams to help you and your patients. So we look at all therapeutic modalities. I may come and help with the medications, but Vera and Margaret and Diane do all the rest of it. So it's mandatory to look at individualized care plans, individualized based on what the symptoms are of that patient. Careful documentation. Look at the target behaviors you're treating, and I'll talk about that in a minute, and adjust the medications to the lowest possible dose and use the right medication. Okay, so let's talk about necessary. What does the necessary, not just in this case, but for any condition? Well, if you're using Lasix or digoxin or pain medication, you must have a supporting diagnosis. You can't just say, I'm going to use Lasix for something, right? It's not going to fly. Reason listed in the medical record. You must say, I think this patient has CHF, they need Lasix and DIG, whatever. Adequately monitored. Someone has to keep track of it. Age-appropriate dosing. We lower doses for everything else. This is a very special, sensitive population. For long enough, but not too long, appropriate duration. It can't be duplicative. So if you're using, one antihypertensive, you add another one, it's going to give you double or quadruple the side effects. So be careful with that. Monitor those patients and then document the benefits or risks or side effects. So it's no different with these drugs. These are not some mysterious, elusive drugs that you do something different with. And let me ask you this question, and it's not tongue-in-cheek, I mean this sincerely. Who are we treating? Who are we treating? Is it the caregivers? Is it the patients? Or is it the family members? Or all of the above? Sometimes I jokingly say, 1 for you and 2 for me. Right? You know what I'm talking about? This is often the driver. What is driving the utilization? It's also lack of training of non-drug methods. I think people just don't think about them. It takes more time and more effort to think about non-drug efforts, but it's well worth the investment. And if you find a good answer for something, let people know. Let us know. We'll put it somewhere so other people can access it. Okay? If you come up with a brilliant idea, don't keep it to yourself. Share it. Okay? So this requires teamwork and requires thinking outside the box. So if we're using drugs like these, why are we still using them? And we've talked about what to do here is to pause and reflect and think, and you need to plan, implement, and then review. That the PDSA cycle. You need to pause, think, reflect, do, and then review for every single thing you do. And what I'm suggesting is you look at the symptoms, look at the behavioral clusters. So the symptoms are all over the map. People can be socially withdrawn, can be agitated, they can be psychotic. But if you put these symptoms into clusters, they make more sense. So there's the aggression cluster, which is physical aggression, verbal aggression, or it's aggression when you're providing care for them. So, if I go up to you and say, I'm going to kill you, right? That's verbal aggression, okay? But if I actually hurt you, that's physical aggression, kicking, biting, scratching. So that's how you define it. Psychosis are hallucinations, delusions, and so on. Then the other circle there is the anxiety and depression cluster. And then there's the apathy cluster. You notice some overlap between apathy and depression. And you notice overlap between aggression and mood, aggression and agitation. Okay. I left agitation till the end because it's a little bit tougher, but it's not that hard to understand. Agitation is simply purposeless activity, purposeless motor or verbal activity. So I'm tapping. Help, nurse, take me home. That's agitation. It's purposeless motor or verbal act. That's not aggression. That does not require an antipsychotic. Okay. It's the aggression and psychosis that requires an antipsychotic, not the agitation by itself. If they also have psychosis, that's different. You all with me on that? It's fairly straightforward. Okay. And you need a way to measure it. We use all kinds of instruments to measure lots of things. And there's lots of scales out there. But, this is one. If you Google this, you'll find it. You're very welcome to download it. It's free, called the Behavioral Vital Signs tool. It helps you monitor the symptoms and the clusters I just talked about. And if you turn the page around, you can actually track how frequently it occurs, how severe it is, and what the impact is. Okay. So, and the concept of using medications, they're very similar to using a brace or a cast because it gives you some relief from the symptoms, it gives you time to heal, and it allows your functioning to be better, right? All three of those things. So just think of them as a chemical brace for a period of time. And the time is variable based on the symptoms, severity, and the age of the person. Sometimes people need them for a longer time. Sometimes they only need them for 2 or 3 days, and you stop them. Okay. So this is an approach that I wrote about called the SMART approach. So safety is number one. Using all your medical skills to make sure you're treating the delirium. Number 3 is assess their capacity to make decisions and to give you direction if they can't. You have to go to the SDM. Look at their finances, driving, etc. Look at the rest of the patient. The rest of the patient includes sleep, weight, appetite, hydration, nutrition, bowels, bladder, skin, teeth, feet. Look at all of the rest of the patient. And then think about medications. Okay? This is an algorithm. I'm going to try and move through this pretty quickly now. This is just some statements from the American Geriatric Society and the American Association of Geriatric Psychiatry. Basically, going back to 2002, before the warnings came out, they haven't changed. If you use these drugs the way they're meant to be used, you'll be fine. But if you use them outside of the way they're recommended, it will get you into trouble. These 2 papers I've included in here are really good if you wish to look at them. This is a meta-analysis basically saying that when you compare all of the atypical antipsychotics, the ones that stand out are, for efficacy, are risperidone and aripiprazole, but not olanzapine. And in terms of side effects, they're significant. In most patients, the benefits do not outweigh the risks for long-term use, okay, for most patients. So you should use them for as short a time as possible. And mortality is increased in those patients who are treated with drug. Okay. The other study here is the DART-AD study showing that if you keep the patients on it for 1, 2, and 3 years, the mortality is significantly higher. Okay? So at the end of 3 years, only 30% of patients survived versus 59% of non-treated patients. So if you go back to the older drugs like Haldol and chlorpromazine, they're even worse. They're even worse. Okay, so they don't have black box warnings, but they don't have the studies to show it. But we know that the odds ratios are greater. Finally, I just want to talk about consent. I think I've talked a bit about the consent, so I think you need to spend time talking to your patients and families about this, but also remind them that if you don't treat them, they can hurt themselves and others. They are at increased risk for falls if they're agitated, malnourishment, not having their ADLs as needed. They'll be isolated or restrained, and refusal of medication is not good. There's a lot of new side effects of these drugs which you should probably be aware of. And then there's the other drugs which I won't talk much about, but cholinesterase inhibitors, memantine, are useful in early stages of the dementia, but not so much in the later stages. And remember, your medical drugs can cause problems as well. So try and be aware of the anticholinergic side effects. And I will stop at this point.